Hi everyone. In this video, we are going to study about a disorder which is non-Hodgkin lymphoma. So truly speaking, this topic is not much more important from exam point of view, but sometimes you may get some questions about follicular lymphoma and Burkitt lymphoma. They may ask about what is the translocation commonly involved for this disorder, or what is the morphology you can see for the disorder, or IHC marker. Okay. So, okay. So today I'm going to cover about WHO classification of the lymphoid neoplasms. After that, I'm just going to describe some 6 important non-Hodgkin lymphoma, which includes follicular, mantle cell, DLBCL, which is diffuse large B-cell lymphoma, Burkitt lymphoma, marginal zone lymphoma, and T-cell non-Hodgkin lymphoma. Okay. Okay. So first, I'm coming with the WHO classification of the lymphoid neoplasms. In precursor B-cell neoplasms, I'm going to talk about the only important thing, which is you should know. You should from here you should only know what is the name for which disorder what belongs, because sometimes the question in MCQ they may ask which of the following belongs to peripheral B-cell neoplasms, or which of the following belongs to peripheral T-cell neoplasms. So you may get some questions like this in your MCQs. Okay, in precursor B-cell neoplasms, we having ball, which is B acute lymphoblastic leukemia. In peripheral B-cell neoplasms, I just marked some things which we all know. Okay, the tick mark I put over here, which is already in our channel. You just have a look over there, and um, other things, which is mantle cell lymphoma, follicular lymphoma, marginal zone lymphoma, diffuse large B-cell lymphoma, Burkitt lymphoma, which is I'm going to teach you today. So other than that, you should know what the other thing: B-cell pro-lymphocytic leukemia, lymphoplasmacytic lymphoma, splenic and nodal marginal zone lymphomas, extranodal marginal zone lymphomas. These all conduct peripheral B-cell neoplasms. Okay. So third one is precursor T-cell neoplasms. In this we have TALL. And coming to the fourth one, which is peripheral T cell and NK cell, natural killer cell neoplasms. Just know the highlighted ones only, because other things is not very much important. You just have a look over the highlighted things, which is mycosis fungoides or Sézary syndrome. The next one is anaplastic large cell lymphoma. And the next one is adult T cell leukemia lymphoma. These highlighted things only I'm going to teach you. Not very detailed, because this is a very rare disorder. I'm just focusing on these 3 things. And the Hodgkin lymphoma, which is already available on the channel. You just have a look over there, which includes classical subtype and non-classical subtype. In classical subtype, we have nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depletion. In non-classical, we have lymphocyte predominance. Okay. So, okay. So I put over this because you should know where the mantle cell or marginal zone, marginal cell lymphoma, or what or follicular cell lymphoma arises. Okay, you should know which lymphoma arises from which site. Okay, so here you can see I have put out a sectional view of a follicle. Here you can see a pale staining area, which is known as germinal center. Around this germinal center, you can clearly see there is a darkly stained area, which is known as mantle zone. Around this mantle zone, we have marginal zone. Okay. Whenever any lymphoma arising from this mantle zone, we call it as mantle cell lymphoma. And similarly, when it is arises from the marginal zone, we calling it as marginal cell lymphoma. Okay. And you should also know CLL, which is chronic lymphocytic leukemia or lymphoma arises from naive B cell. Okay. This I'm going to explain in the next slide. Okay. Follicular lymphoma, Burkitt lymphoma, diffuse large B-cell lymphoma, Hodgkin lymphoma. These all are going to arise from the germinal center. Okay. And DLBCL, which is diffuse large B-cell lymphoma, CLL, marginal zone lymphoma, arise from marginal zone. You may ask how DLBCL comes at 2 site. Okay. Sometimes DLBCL marginal zone may arise from the 2 site. Okay. DLBCL, CLL, marginal zone lymphoma arise from the marginal zone. Okay. So moving on to the next slide. Okay, this is a diagram which is described in Robbins. Okay, here you can see from the common lymphoid progenitor, which is pre-B lymphoblast. From pre-B lymphoblast arises precursor B lymphoblastic or lymphoma or leukemia, which is ball. Okay, BALL. from BLB region, which is pre-B lymphoblast, we get ball from the naive B cell, which we already seen in the previous slide. From there, we are getting SLL or CLL. Okay, and here you can see the lymph node cross section view is depicted over here. From the germinal center, we are getting follicular lymphoma, Burkitt lymphoma, diffuse large B-cell lymphoma, Hodgkin's lymphoma. One simple trick I would like to give you here is how I remembered from germinal center which lymphoma arises. Just remember as BDFH. Okay, BDFH. I mean in the I'm going in the alphabetical order. So B first comes D and FH, Burkitt lymphoma, follicular lymphoma, and follicular lymphoma and Hodgkin's lymphoma. Okay. From marginal zone, we are getting diffuse large B-cell lymphoma, marginal zone lymphoma, which is self-explanatory, and sometimes SLL or CL arise from the marginal zone. Okay. Moving on to the next one. So I'm going to describe some 6 important topics here. The first one is follicular lymphoma. Okay. So I'm going to teach you about what is the pathogenesis. So in every lymphoma, I'm going to teach about what is the pathogenesis, which translocation is commonly associated with that particular disorder, or what is the IHC marker, or what is the morphology we can see for that. Okay. So starting with follicular lymphoma. Follicular lymphoma is the most common form of indolent non-Hodgkin lymphoma in the worldwide. You should remember this because sometimes you may get some MCQ regarding this. So it presents in middle age, and male and female both are commonly affected. Okay. So talking about the pathogenesis, it is strongly associated with chromosomal translocations involving BCL2. You should know here the BCL2 is mainly involved. Okay. And the main translocation or the hallmark is 1418. So one trick I would like to give you all is FR14, FR follicular, FR14. Okay. So remember it as T1418 translocation. Instead of 1418 translocation, IGH locus is present in the chromosome 14 and BCL2 is present in the chromosome 18. Okay. And one simple rule you should remember is that whenever IGH locus is present with uh, any other expressed site, it increases the other one. Okay. Here you can see IGH and BCL2 both are going to translocate from this, but BCL2 expression going to be increased because it's an anti-apoptotic gene. Okay. So as we all know from the general pathology, BCL2 is an anti-apoptotic gene. So when BCL2 is expressed, then from the name itself, we can make sure that the cell is going to proliferate. Okay. From that, we are getting follicular lymphoma. So the next one is morphology. So in morphology, in lymph node biopsy, we can get as a nodular and diffuse growth pattern is observed. Okay, I'm just going to teach you in the next slide. So when we observing in the lymph node biopsy, the cells are going to arrange in follicles. Okay, there you can see several cells arranged in follicles, and in follicles you can see 2 types of cells. Okay, one is centrocytes and another is centroblasts. Just see here. Here you can see several follicles. Okay, cells are arranged in follicles. And in this diagram, you can see there is 2 type of cell. One is very large and one another is very smaller. Okay. This larger one, we call it as centroblasts, and the smaller one, we calling it as centrocytes. Okay. In centrocytes, you just see there is a cleaved nuclear counter in the center. Okay. So it's for centrocytes. For centroblast, you can see there is several nuclei and there is several prominent nuclei are present over there. Okay, this is for centroblasts. Okay, just like looking onto the theory part, centrocytes, which is small cells with cleaved nuclear counters, which I put it over there. Okay, and it has scanty cytoplasm. In centroblasts, these are large cells with open nuclear chromatin and having several nuclei. You saw that in the image. There are several nuclei, yes. And it has the same scanty cytoplasm, okay? And on bone marrow aspirate, you should know, and I have put over a star mark over here, and you should know in bone marrow aspirate, what we are getting is paratrabecular lymphoid aggregates. This is nothing but when you are getting the bone marrow aspirate, na, there is lymphoid aggregates can be seen in the trabecular bone. So that's why we are calling it as paratrabecular lymphoid aggregates. Okay. And here you can see a gross image of the spleen. It's not normal image, okay? Because you can see there is several white spots. Okay, these white spots are nothing but actually white pulp follicles. Okay, these are actually white pulp follicles which is present in the follicular lymphoma. Okay, so and the most important thing you should remember is IHC marker. Okay, so there is several IHC marker which is CD19 positive, CD20 positive, CD10 positive, BCL2 positive, BCL6 positive. How I remembered as because as we all know CBME started from the 19 batch. So how I remembered is 19, 20 positive and CD10 positive because I rate everything with cricket. Okay. So my favorite player is Sachin Tendulkar. So how I relate is because his jersey number is 10. So it's going to be CD10 positive. And it's also BCL2 positive and BCL6 positive. As from the pathogenesis, we can say, okay, it's going to be BCL2 positive. And remember as it's BCL6 positive. And in 30 to 50% of cases, what we are getting is follicular lymphoma may transform into diffuse large B-cell lymphoma. Okay, so just look on this diagram. You can clearly see there is several brown color. This is fully brown colored stained. So this is actually nothing but these are IHC marker positive. Okay, whenever we are testing anything and when it comes out as IHC marker positive, so it's going to be brown stained. So talking about the clinical features, they present with painless generalized lymphadenopathy. Okay, and extranodal sites are very uncommon in follicular lymphoma. So moving on to the next slide, which is the second disorder of today's topic, which is mantle cell lymphoma. Okay, so it's uncommon, and here it's mainly affecting the male. So talking about the pathogenesis, the main translocation in the mantle cell lymphoma is T1114 translocation. Similarly, in 14th chromosome, we are having IGH locus. In 11th chromosome, cyclin D1 is present. Okay. So, once again, I would like to tell that whenever IGH locus is present with another thing, it increases the expression of the opposite one. So, cyclin D1 is expressed similarly from the general pathology, as we all know that whenever cyclin D1 is increased, okay, it moves a cell cycle from G1 to S phase. So thereby it increases the cell proliferation, thereby causing the mantle cell lymphoma. Okay, just have a look over these two images. So here you can see there is several lymphoid follicles, but here you can't able to appreciate the germinal center because the germinal center is atrophied over here, and here you can see images of similar to that of centrocytes. Okay, so here in this image you can see there is several lymphoid cells. Okay, there is several cells of homogeneous population of cleaved nuclear counters. Okay, so here you can see the extranodal involvement here is quite common. In follicular lymphoma, which is uncommon, but here extranodal involvement is quite common, which include bone marrow, spleen, liver, and gut. Okay, and the important thing you should remember is sometimes in colon, you can see some polyp-like lesions, okay, which is present in the colon. So that's what they are calling it as lymphomatoid polyposis, okay. You should remember the name lymphomatoid polyposis, which is present in the colon. In lymph node biopsy, I shown in the previous slide, there is homogeneous population of small lymphocytes. Yes, you saw that now small lymphocytes which are spreading over over that image, having irregular to occasionally deeply cleaved nuclear counters similar to that of centrocytes. Okay, so talking about the IHC marker, you just know the name. That's it's from the pathogenesis. It's obvious that it's going to be cyclin D1 positive. Okay, and it's CD5 positive and it's CD3 negative. Hmm. So talking about the clinical features, they present with painless lymphadenopathy, and symptoms are related to involvement of the spleen and gut, because here you can see extranodal involvement is quite common. So um, so when spleen and gut is involved, you are going to see the symptoms of those specific organs. Okay. So moving to the third, which is diffuse large B cell lymphoma. Okay, this is the most common form of non-Hodgkin lymphoma. Don't confuse it with a follicular lymphoma. That's one is indolent. It's most common form of non-Hodgkin lymphoma. It's a very aggressive tumor, okay, having very poor prognosis. So talking about the pathogenesis, similar to that of follicular lymphoma, they have a translocation of T1418 translocation or dysregulation of BCL6. So it's a diagnosis of exclusion, okay. They're just eliminating the other diagnosis and they're arriving at the diagnosis of DLBCL at later stage. Okay, talking about the morphology, just to see, I have put over a diagram of lymph node biopsy showing that there is complete effacement of lymph node architecture. You can see, okay, the lymph node architecture, which that means the lymph node architecture is completely destroyed. Okay, so it's completely destroyed, and there you can see there is pleomorphic large cells with prominent nuclei. Okay, here you can see there is so much lymphoid cells and having irregular shapes. Okay, so that's why we are calling it as pleomorphic, having prominent nuclei. And here you clearly can see there is the size of lymphocyte is very larger. So that's why we are calling it as diffuse large B-cell lymphoma. So here you can see an image of spleen. It involves the DLB cell affecting the spleen. So large destructive masses can be present over the spleen. Okay. So talking about the IHC marker, you should know that it's BCL6 positive and surface immunoglobulin positive. From the pathogenesis, we are clear that it's BCL6 positive. And remember that it's also surface immunoglobulin positive. There is two special types. One is primary effusion lymphoma and another one is immunodeficiency associated diffuse large B-cell lymphoma. In primary effusion lymphoma, it is HHV 8 association, which is human herpes virus 8 associated, and it presents with pleural effusion. Talking about the immunodeficiency associated diffuse large B-cell lymphoma, it is HIV associated, okay? And it's associated with transplant recently undergone patient who have uh, recently uh, recently those who have undergone any transplant, okay? Moving to the next one, which is Burkitt lymphoma, very important from the exam point of view, because if any question going to ask from this topic, this is going to be Burkitt lymphoma, okay? So talking about the pathogenesis, the translocation, the most common involved translocation is 814. So you just remember it as B looks similar to that of 8. Just remember it as 8 and 14. Okay. In 14th chromosome, we are having IGH locus. In 18th chromosome, C mic oncogene is present. Okay. So similar that C mic oncogene is going to be overexpressed. So thereby causing Burkitt's lymphoma. So you should also remember other translocations. How I remember this, I once again I like to tell that I love cricket a lot. So okay, so my favorite player is Sachin Tendulkar. His jersey number is 10. Okay, so to get 10, I need to add 2. So thereby I put it 2 here and similarly 2 over here. So I'm getting translocation as 28 and 822 translocation. So moving to the next slide. So here there are three categories. Okay, the first one is African or endemic. Second one is sporadic. Third one is HIV associated. In African or endemic, most of the cases are Epstein-Barr virus associated, and the most common site includes jaw and mandible. Okay, in the sporadic one, we can see it's not totally EBV associated, but 15 to 20% cases are EBV associated, and the most common site includes GIT, ileocecum, and peritoneal mass. Okay, in HIV associated, it can occur anywhere. So moving to the next one, here you can see the African endemic type. Here you can see a very huge lesion present in the jaw and the mandible area. And here you can see there is a clear swelling in the abdominal region area. So this one is sporadic one, okay? Which I talked now. That's the most common site is ileocecum, GIT, and peritoneal mass. Okay. Yes, you should not remember. You should not forget about this. Okay, this lymph node biopsy. There is starry sky appearance you can see because Why they are calling a starry sky? Because just compare this diagram or this starry sky appearance. Here you can see there is so much lymphoid cells. In between these lymphoid cells, we can see macrophages in between those lymphoid cells. So that's why they are calling it as starry sky appearance. And just look it over here. Here you can see there is so much lymphoid cells. Okay, but here you can see several white spots in the lymphoid cells. This actually nothing but vacuolated cytoplasm containing fat. Okay, so this is a image of bone marrow aspirate, and this is an image of lymph node biopsy. Okay, you should remember that marker for rapid proliferation is MIB1 index and K67 score. You should remember this one because sometimes MCQ may frame from this. And marker for Burkitt lymphoma is BCL6 positive. So talking about the clinical features, both endemic and sporadic are commonly found in children or young adults. So they commonly seen at extranodal sites. Okay, it's very aggressive tumor, but a very good thing is they respond well to intensive chemotherapy. So the next one, which is the fifth topic of today's lecture, is about marginal zone lymphomas. So they are oftenly referred to as maltomas. Okay. So initially they recognized that maltomas occurred at mucosal sites of stomach, but gradually they found that it may also arises at sites of chronic inflammation like Hashimoto's thyroiditis, and also in H. pylori infection and Sjogren syndrome. Talking about the pathogenesis, it's similar to that of mantle cell lymphoma, that its translocation involves T1118, and the markers are CD43 positive and CD5 negative and CD23 negative. Okay. So the last one, which is T cell non-Hodgkin lymphoma, which is quite uncommon, very rare disorder. Just to know these names and you're ready to go. Okay. So talking about the adult T cell leukemia, so the pathology here is human T leukemia virus 1, and the histology looks similar to that of flower leaf cells or clover leaf cells. I just going to teach you in the next slide. So talking about the second one is mycosis fungoides or Sézary syndrome. They just usually affect the skin. So that's why they are calling it as cutaneous T cell lymphoma. Talking about the histology, there is so much cell. They are calling it as Sézary cells. Okay, having nucleus similar to that of cerebrum of our brain. So therefore, they are calling it as cerebriform nuclei. And there are so much abscess present over the skin. So that's why they are calling it as Pottier's micro abscesses. Talking about epidermotropism, why they are calling it as like because T lymphocytes just invades the epidermis. So that's why they are calling it as epidermotropism. So the last one, which is anaplastic large cell lymphoma, which is ALCL. Here the pathology involved is ALK gene on chromosome 2p, and the histology is it just resembles to downed cells. Okay, because in downed cells we can see clearly there is a central space which is empty. So they just appear to that of downed cells having voluminous cytoplasm. Okay, just remember these things and you are ready to go. And just see um, the first one which I mentioned, that it's look exactly to that of clover leaf cells, and you can clearly appreciate here, you can clearly appreciate it looks similar to that of clover leaf cells. Okay, and the second one, which is mycosis fungoides, here you can see there is so much nuclei but they are looking very irregular, so that's why they call it as cerebriform nuclei. So moving to the third one, which is the last one, ALCL, having a voluminous cytoplasm. Okay, so they look similar to that of downed, so that's why they call it as downed cell appearance. So this is a brief summary of what we um, saw today. Okay, you just remember these things and you are just good to go. So if you like this video, thank you everyone for listening till this now. um, If you have any queries, just mail us to medimentorz@gmail.com. If you like this video, put a like and share with your friends and subscribe to our channel. Thank you, everyone.